Hello, welcome. Happy Monday. It is a new week, and somewhat excitingly, it is week 14 of the semester. We are almost there, right? We have gotten through now officially 1 month of last second online instruction. We've gotten through 1 month of having to make this switch on very, very short notice. This week, we will be discussing somewhat serendipitously health and healthcare. I say serendipitous because we are currently in a time of history or a time of current events where many of us are thankful to have health and healthcare, provided that we have it. So this is a topic of pretty clear importance, not just normally. People always say things like, well, at least I have my health, or maybe that's just people my age. As we start to age and deal with life's disappointments, we start to say things like that. But nevertheless, it's pretty clear when we look at the ongoing pandemic, what it means for your life chances to lack personal health and to lack social health, right? To lack health care and access to, most importantly, affordable health care. So here's my goal for the day. I will first want to start with the topic of demography. Demography, as I've said a few times, is the study of human population. Then I want to turn my attention to the social determinants of health. These are topics that are going to be very important for the next assignment and also the final assignment. And then I'll wrap up with the discussion of health and inequality, how inequality is something that is very damaging to both our own personal health and something that's very damaging to social health, right? To the ability of an entire society to maintain a high level of healthfulness. I'm actually not sure if healthfulness is a word, but hey, academics love creating words where there weren't words before. So maybe that's just going to be mine. In the way of announcements, you will all be completing your final reaction paper this week, okay? Group A, Group B, doesn't matter at this point. All students, I would like to write this final reaction paper to prompt 8. To do that, you are going to want to pay very close attention to two materials I've assigned to you. The first is the article Paying Till It Hurts by Rosenthal, Elizabeth Rosenthal, I believe. And you will also want to watch very carefully this PBS documentary that I've assigned to you called In Sickness and in Wealth. It should be pretty clear from that title that this is a film that is discussing both social determinants of health and health and inequality. So pay very close attention to these videos. And those of you that can draw some stuff out of this and make some real clear comparisons here are clearly going to do the best on these upcoming assignments, okay? So let's establish health. When I want to talk about social phenomena or social institutions, I always try to give a little explanation as to why sociologists care about this in the first place. There's two types of ideologies about health and where it comes from, where our ability to be healthy comes from. One is what's in our bodies, our genetic code, right? Our pre-existing strengths and risk factors at the genetic level. So for me personally, I am well aware that there is a history of prostate cancer in my family among men. So very clearly, I need to be getting my prostate checked at an earlier age than most men. I know what my risk factors are, and that's very helpful here. Also, when we think about race and health, different racial and ethnic groups tend to be prone to different health risks. And so it's helpful to sort of know what the genetic makeup of various groups is, and that's a way to distribute healthcare in the most efficient way possible. But that's really more like, if you're really interested in that, go to medical school. There's definitely a need for people to understand the genetic and the biological basis of health, and to be able to treat us appropriately and accordingly, depending on what our risk factors are. The other side of health is much more interesting to sociologists, which is everything else that happens once society gets its hands on you. We are born into a society that makes us more likely or less likely to experience certain outcomes, to be prone to certain risks. How could that stuff not be meaningful to us? We know that social class has a big effect on certain risk-taking behaviors like alcohol consumption and tobacco usage. We know that something like gender and sex and gender roles plays quite a big role in your willingness to seek out preventative care and your willingness to take care of yourself in certain preventative ways. And just more theoretically, health is a prerequisite for a functional society. We are seeing that right now. We are in a position right now where, because of a pandemic health risk, because of a health risk that everybody's prone to in some way or another, our society has had to ground to a halt. I'm teaching online. You're having to learn online. Most of the country is having to stay at home. Various essential workers are having to put themselves at risk every single day in order to keep even the most basic elements of society going. And it doesn't feel very functional to me. I'll tell you that. It does not feel very functional to me. So if we have too many sick people or we have too many health risks, we cannot have full social participation. That is very clearly what's happening right now. And also, people who are sick are often not able, they are often what's known as dependents in a society. And I don't mean that in like a Republican kind of people are just taking and they're not contributing type of ideology. I just mean that we know that children are generally a net economic cost. We know that the elderly are generally a net economic cost. And so we do that for very clear moral reasons. If you've spent your entire life working, you shouldn't have to die in the streets just because you're too old to work anymore. And that's where things like Medicare, Medicaid, and Social Security come from. But if we have too many people who are not able to contribute, those are sunk costs in our society that are very expensive and very hard to overcome. So societies that have very endemic health problems ultimately risk just full-scale collapse. I don't think that's what's going to happen in Europe and the United States, but we are seeing a small-scale version of what social collapse would look like. The term we have for this in demography, which again is the study of human population, is a high dependency society. A high dependency society is a country or a local area that has a critical mass of people outside of the labor force and therefore dependent upon social support. So we can have a high dependency society in a variety of ways. For example, if you remember back to my lectures on political sociology, you will remember that I discussed this idea of the youth bulge, how you had various if you had various countries in sub-Saharan Africa and the Middle East where you had a very high prevalence of people, sometimes under the age of 20, right? Half of Nigeria's population is under the age of 20. Half of Afghanistan's population is under the age of 17. And that's wild, right? That's just an absolute, that's a high proportion of the population that needs support from others. Another example of a high dependency society that actually nobody would argue is in bad shape is Japan. Because Japan has their life expectancy in Japan is number 1 in the world. Their fertility rate in Japan is 184th in the world. So they are not producing enough workers to support the elderly who are living longer and longer and longer lives. And it's put a lot of stress on the pension system, a lot of stress on the healthcare system. Japan is already a country that has issues with racial purity, so they're very, very resistant to immigration and always have been. And so as a result of that, they don't have enough young workers to pay into the systems that support this incredibly large elderly cohort. Now, what that would mean for health, right? Look at countries like South Africa, Uganda, and Zambia, countries that have very high rates of HIV, very high HIV prevalence rate. In South Africa, 25% of the country is HIV positive. this ripples out, like all that disease. You don't think that ripples out through a society? That creates some really serious problems for the country itself. It puts a lot of people into the health system, like who need to be taken care of in what is supposed to be the prime of their lives. If you look, Zimbabwe is another country with that has been ravaged by HIV. In Zimbabwe, the life expectancy is 36 years old. 36. I never personally thought of 18 as middle-aged, but that's what it looks like in Zimbabwe. And it's because all these people generally dying young. And what that has created in sub-Saharan Africa is an entire generation of children who are currently known as AIDS orphans. Children who are orphaned because their parents died of HIV. And then that puts stress on the orphanage system, on the social work system. And you end up with a lot of children very vulnerable to being preyed upon by, at best, predatory child labor companies that want to exploit children for their labor because they don't really have a choice. At worst, it's for sex work. But, I don't really want to go too far into that. Anyway, the point of the story is high dependency societies are not functional for anybody. So thinking of this in a very functionalist type of framework, health is important, not just for you, not just for me, but for our whole society. Okay. So now if we look at the world, I can very clearly see the effects of social institutions and the effect of the general well-being of a society on people's health, on people's ability to live long lives. So the countries you see in darker here in red, those are countries with lower life expectancies. Anything in light blue and dark blue, countries with higher life expectancies. So should I be looking at this and saying, and also, if you remember back in when I did gender, I talked a lot about specifically Russian male mortality. And you can very much see this on the map here, where Russia, we always think of being more culturally similar to Europe, especially Eastern Europe. But when I look at the colors here, it doesn't look like Poland and Slovakia. It actually looks a lot more like Pakistan and Nepal, which is not company that you ultimately want to be keeping if you are the Russians. So how should I read this? Should I look at this and say, all right, let's look at this country right next to Pakistan. That's Afghanistan right there. Should I look at Afghanistan's color and France's color and say, well, the French are they're just naturally a healthier population. They're just naturally less resistant to disease. Or should I look at this and say, Afghanistan has had 20 years of being a failed state and living under conditions of tribal warfare and an invasion from the United States, and France has not. Should I look at this and say, all right, well, the UK is just naturally, the Canadians are just naturally healthier than the Angolans? Or should I say, again, the Angolans have had to deal with state failure, civil war, and an HIV epidemic in a way that Canada just has not. So if I look at this, a lot of these countries with very low life expectancies, very high infant mortality, very high child mortality, I find them very explainable. I can look at this and very easily see why countries are doing well and why countries are not doing well here. And that leads me to a discussion of what is known as the social determinants of health. I'm going to read this. This is a direct quote from the director of the Public Health Agency of Canada, one of the healthiest countries in the world, because I just think this is put very beautifully. I don't think I even have the ability to paraphrase this in a way that is as succinctly and intelligently put as the Public Health Minister of Canada has put this here. There is mounting evidence that the contribution of medicine and healthcare is quite limited, and that spending more on healthcare will not result in significant further improvements in population health. To give you further insight on that, I'm going to be talking more about spending money on healthcare next time on Wednesday. But for now, I'll just tell you some of the simple data. The United States spends more money on healthcare than any other country in the world. And I don't mean a little bit more than any other country. I mean a shit ton more. And not just like in raw numbers, because we are a big country. So it would make sense that we have more people to spend money on. No, I mean per capita. We're spending double what the Canadians are spending per capita. We're spending 2.5 times what the Swedes are spending per capita. And maybe that would make some sense if we were getting better outcomes for our money. We are not. We're 33rd in life expectancy, 36th in infant mortality. We're 46th in maternal mortality. And the World Health Organization ranks the structure, like the efficiency of our healthcare system, something like 17th in the world. So we are just not, like, we're throwing all this money at the health of the population, and it is very clearly not working. So what do we mean? What is the Canadian health minister? What do these people, like, what is this term of the social determinants of health mean? It's everything else in society that will affect your ability to translate whatever your natural risk factors are into, like, despite those natural risk factors, into a very healthy life and lifestyle. Okay, so if we go through some of these, like, obviously the determinants of health, notice how this flowchart does not say social, it says the determinants of health. So let's start with just biology and genetics. Well, that's, who were your parents? What were you born as? Like, were you born very lucky or unlucky in terms of what's in your history? But then also, when we look at personal health practices and coping skills, here's what we know. Like, we are well aware that men who get cancer are more likely to die of cancer than women are. And it's likely because for two reasons. A, they don't prioritize preventative care, so they don't catch their cancer as early. And secondly, social networks, right? The willingness to lean on others and to receive support from others and help from others is slightly lacking in comparison to what women are often willing to do. So that's what's meant by personal health practices. Healthy child development. Again, if you look at many countries in Africa and the Middle East that have had recent civil warfare or ethnic warfare, immunizations, prenatal and neonatal care, all that just goes away during a war, during civil war. And so healthy childhood development, are you getting inoculated against various things? Health services and social services. That's probably the primary reason why the Canadians live longer and better than Americans do, or why, the average European man lives 4 years longer than the average American man. And that's despite the fact that Europeans actually drink and they smoke cigarettes at far higher rates than Americans do. And yet, but there are social services in those countries that are just unheard of here. Social environments. Think about something like stress. That's going to become very important for the video I assigned for Friday. Gender. Well, we already talked about that at length. Culture, willingness to ask for help, willingness to look into social services and trust of healthcare institutions. Your income and social status. I don't feel like I have to say all that much about that, but education, which then determines what type of job that you get. So that goes right next to employment and working conditions, and that determines what type of place you're likely to live in. So physical environment. Connect the freaking dots, guys, and you will see how much of health is socially determined. And in fact, whenever you go to the doctor, especially once you get into my age, like into your 30s, which is like this is the time in which people set themselves up for a long life or a short life, unfortunately. When I go to the doctor for my physical, which I just started doing a few years ago, again, after 10-year absence from the doctor, the doctor will ask you various questions about your lifestyle, you exercising, you smoking, things like that. But they also ask you certain things about, like, what are you doing for a living? Are you happy with what you're doing for a living? There's a reason why they're asking you these things. Like, where do you live, right? What's your family situation like? And that's doctors understanding that the social determinants affect the physical determinants of health. And so think of it, like, look for that the next time you go see the doctor for like a physical, not if you're going in because like you think you might have the coronavirus or something, but beyond that, like when this gets back to normal, God willing, and you just go for a physical, for a checkup. Look at how many questions they ask you that don't really have much to do with your genetic risk factors or what's already wrong with you. Okay, so as a way of kind of pricing this out, if we look at the annual number of deaths that are attributable to social factors, low education is thought and estimated to cause almost 250,000 deaths every year. Now, when somebody dies and the mortician lists a cause of death, or somebody does an autopsy and lists the cause of death, they never write down low education. They write down something else. They might write down heart disease. But if you connect the dots here, you can see that low education makes one much more likely to be working in an area with working in an industry that doesn't make a lot of money, say the service sector, manual labor, physical labor, things like that, which leads to not just a deterioration of the body, but it also leads to a lot of stress, the stress of living paycheck to paycheck, which many poor and working class people are doing. Over time, that leads to a hardening of the arteries, and that leads to heart disease and a heart attack when you're 55. And so low education, like what really killed that person? Racial segregation, 176,000 deaths. I think I've mentioned a neighborhood. I forget which class I would have mentioned this in. It might have been in my cities class. But I mentioned there's a neighborhood on the south side of Columbus, Ohio called Linden, South Linden, Columbus, Ohio. There's no reason why it should be known, but the reason why it is known is because it's the urban neighborhood with the highest infant mortality rate in the country. And this is a neighborhood that is 4 miles away from the Ohio State University Wexner Medical Center, one of the highest rated healthcare providers and research hospitals in the country. But if you ever go through Linden, you ever drive through South Linden, it will immediately make sense to you. There's no bus routes that serve it. It's 97% Black, so it's got a history of deep racial segregation and racial inequality throughout the area. There's virtually no jobs. It's very, very far away from the economic hubs of the Columbus metropolitan area. And so when babies die in South Linden, it's not because they're particularly prone to that. It's because those babies are in an environment where they're very cut off from prenatal care and neonatal care and any type of social system that would lead to giving a shit about those people in the first place. And again, if that makes you sad, hey, be sad. But that's the reality. And there's no reason why it had to be that way. But things happen how they happen, and we get the cities and the neighborhoods that we have. Low social support. Tens of millions of people in the United States that do not have access to health insurance. That number is way down since Obamacare and healthcare reform, but that was actually a deeply flawed piece of legislation for reasons I will get into on a later point, and it's not flawed for the reasons that Mitch McConnell says it's flawed, for other reasons that I want to get into. Individual poverty and inequality, 133,000, 119,000. Area poverty, living in a place of concentrated neighborhood level poverty, 39,000. Let's compare that to annual causes of death for other things that would end up on your autopsy, let's say. So in comparison, 192,000 people die every year from acute myocardial infarction. That's a fancy way of saying a heart attack. So let's round up and be generous and say 200,000 people die from a heart attack. Cerebrovascular disease, that's a fancy way of saying a stroke, 167,000. Lung disease, 155,000. If you tally this up, you will see like something like low education or failure to have a functional education system is more deadly to us than heart attacks are. Now, granted, I am drawing a line there where I probably shouldn't, because like low education, racial segregation, like if I'm arguing those can't be separated from health, that's related to the rate here for a heart attack, for a myocardial infarction. But nevertheless, if we're just trying to price out, like, what's the thing that's responsible for this, I'm seeing that that's actually deadlier to us than heart attacks are. But it's very easy to see somebody that dies of a heart attack. It's much harder to see somebody that dies because bad education systems put them on a path that led to them dying at 52. And that's sad to me. But recognizing that is probably the first step towards actually constructing a society that's healthier for everybody within it. Tell you one quick story about this. I don't know. I know I've said this a lot in one of my other classes. I don't know if I've told you guys. My least favorite city in the country, the city that I absolutely cringe at the thought of going to, is Atlanta, Georgia. I hate Atlanta for numerous reasons. One, it's outrageously humid, like even in a way. And I lived in Charlotte, right? I've lived in North Carolina where the humidity is no joke, but it is worse in Georgia. Atlanta also is the real reason, like, why I really dislike it. It is unbelievably sprawled and car dependent. I guess the symbol of Georgia is the peach. It really should be the traffic jam. And so when I was living in Charlotte, I went to Atlanta more than once. And I remember one time I was driving out of Atlanta back, and when I say the traffic is bad in Atlanta, I'm not talking about rush hour. Of course it's bad at rush hour. When I say the traffic is bad in Atlanta, I mean at like 2 p.m. on a Saturday, you're in traffic because the freeways just make no sense. They're late. They're sprawled out all over the city. It is the number one city I would be loath to live in at this point. Like, I would go to Buffalo before I went to Atlanta at this point. So anyway, I'm in one of Atlanta's famous traffic jams, and I'm driving like it was a Sunday afternoon. I'm trying to leave the city and get back to Charlotte. I was there for a conference this time, I believe, Southern Sociological Society. And I remember... Do you know those like if you there are these, you know, those bridges that go over freeways and they're, you know, on top, these people can walk across them, or they're road bridges, but there's always sidewalks on them. I remember sitting at a traffic jam kind of looking up at this situation, right? Looking up at this bridge here, and there was an elderly Black woman in just this outrageous Georgia heat, right? It was a stunningly hot and humid Atlanta day. And this elderly woman is struggling along to walk across this bridge in carrying a bunch of grocery bags. And I remember thinking to myself, if that woman keels over and dies right now, somebody is going to do an autopsy on her, and they will list the cause of death as like heat stroke or something like that. But heat stroke would not have been what killed that woman. What would have killed that woman is Atlanta's inability. It's Atlanta's sprawling nature and Atlanta's inability to connect her neighborhood to the place she needed to buy groceries through any type of public transportation or any type of functional urban planning. And look for that more in your cities. Look for that more in the cities that you come from and the cities that you go to visit throughout your life, about how various parts of this city are sewed together and connected, because it's a primary way in which we access the resources we need to live good lives, okay? As further evidence of this, let's do a social factor comparison. Here are two neighborhoods, Oakland Hills and West Oakland, California. Now, granted, I cherry-picked these pictures a little bit, but I can tell you that these pictures are somewhat representative of the neighborhoods. Oakland Hills and West Oakland, which one of these would you rather live in? And granted, look, I clearly, you know, I'm doing some social engineering here, but for me personally, I'd rather live in Oakland Hills. That looks like a much nicer place to live than West Oakland, California. But if I do a comparison of these two areas, here's what I need you to understand. These neighborhoods are in the same city and they're actually right next to each other. If you're in Oakland Hills, you can trip and roll down the hill and end up in West Oakland. So we're not talking about comparing rural Oklahoma to urban New York City. We are talking about two neighborhoods right next to each other in the same city of California. Oakland Hills has a very high median income. West Oakland has a very low median income. Now, let's price out what the social factor risks are between those two areas. If you are born in Oakland Hills, like compared to the reference group here of a child born in Oakland Hills, compared to that, a child that is born in West Oakland, which was the place that has the much lower median income, is 7 times more likely to be born into poverty. Now, how is that the fault of any child that's born into West Oakland? Like, you are born into poverty the same way that I was born not into poverty. None of us chose that, but that's where we ended up. And perhaps as a result of that, over time, they become 4 times less likely to read at grade level. You think that generally impoverished nature of the neighborhoods probably got something to do with that? I do, because it is local property taxes that fund our education levels, that fund, not our education, pardon me, let me start over. It is our local property values that create property taxes that create funding for local school districts. So a poor area becomes a poorly funded school district, and these child become 4 times less likely to read at grade level. Perhaps as a result of that, of falling behind, they're 5.5 times more likely to drop out of school. Now, perhaps as a result of that, not as a result of that, but related to that, let's say, they're 4 times more likely to be near a high density of fast food or liquor store outlets. Look at this and look at the institutions that surround a low-income area. And if you remember the Hale County, Alabama example that I went over with my podcast that I assigned back in social class, the institutions and the businesses in an area reflect the wealth level of the customer base in that area. So instead of being surrounded by Whole Foods and Trader Joe's, you're surrounded by McDonald's and liquor stores. And perhaps as a result of that, you end up 5 times more likely to be hospitalized with diabetes, hypertension. These are all things that are much more common among the poor and much more common in Black areas. Hypertension is a disease of stress, and diabetes is a disease of poor nutrition. And when I look at West Oakland, it's not surprising. This is a stressful area filled with a lot of poor nutrition, okay? 2 times as likely to die of heart disease. Notice how it says as likely there. The child born in the wealthy area of Oakland Hills is much less likely to die of heart disease, which again represents stress and exercise over the life course. 3 times more likely to die of Sorry, so that's supposed to say 2 times more likely to die of heart disease and 3 times more likely to die of a stroke, 2 times more likely to die of cancer, and has a life expectancy 15 years younger, 15 years less than Oakland Hills. I cannot stress enough how close these neighborhoods are to one another. Like, if you've been to the Bay Area, everything's on a hill, you know? You can literally trip and roll down a hill and end up in West Oakland from Oakland Hills. So when somebody dies at the age of 60 in West Oakland and somebody else dies at 75 in Oakland Hills, what is that reflecting? That's reflecting the connection between conditions of birth to conditions of your society to then the health risks that invade your body. Okay? All right, I'll stop there for a second till I let people catch their breath. So again, what's killing West Oakland 15 years earlier? It might be heart disease and stroke and cancer, but it's really inequality. And that leads me to my discussion here of inequality in health. Inequality literally makes us sick. It makes us sick in a way that's hard to see with your eyes, but you can statistically get the effect of it very, very easily. So here's the correlation. I'm just going to show you some cross-national data here. Health is generally worse in countries with high income inequality. So if we look at this here, infant mortality is often a good proxy for the general health level of like when in a society that has good health, we do not see high infant mortality, like ever. In a society with a high infant mortality, we just very rarely see high levels of wealth here. So down here all the way at the bottom, Japan, Finland, Norway, and Sweden, very low levels of income inequality and very low levels of infant mortality. Up here, Singapore is a major outlier here with very high income inequality. But that's because wealthy Chinese and British people park their money there so they don't have to pay taxes. Again, that's an outlier. The trend here is very clear. Within OEDC countries, high inequality is positively correlated with infant mortality. The more unequal the economy is, the more likely babies are to die in infancy. That's not the baby's fault. That's not your fault if you die at 6 months old. But what's going on there? We'll get to that in a second. When we look at also just life expectancy, so not the babies, but the life at the end of your life, it ends up being lower. There's Singapore, USA, and Portugal. Once again, there's Japan, Sweden, Norway, and Finland at the end of the graph that we'd all want to be generally, although Denmark and Finland have a pretty serious drinking problem, which the number one cause of preventable death in Finland is liver disease because they drink insane amounts of vodka. And that's why you're seeing that a little bit below the trend line. But nevertheless, as income inequality increases, I see a decline in life expectancy among the population. There are the Japanese again, all the way up there at that top area. Very egalitarian society, very high life expectancy. 82 on average, 86 for Japanese women. Unbelievable. Let's bring this back to the social determinants of health. Inequality and other types of social problems are known to worsen social health. I've been building to this argument for a while now. Let's flesh it out. If I have high levels of inequality, that almost implies that I have high poverty rates. Like I have a higher than normal. For everybody that's doing well, there's people that are doing poorly. And everybody's doing poorly, there's people who are doing well. That's the condition of economic and income inequality. So that's very correlated with high poverty. High poverty is very correlated with stress, and stress kills us, particularly men. It's correlated with poor nutrition. So you add that up. I can tell, I think I discussed this a little bit when I was having you guys fill out that budget and making fun of how little everybody was spending on food and things like that. Look, there are two very cheap ways to add flavor to just about anything you might cook and prepare. One is salt. Not great for you long-term to use a ton of it. The other is to fry something in oil. Also not great for you to do that consistently long-term. So that connects to obesity, which is always overrepresented, obesity and diabetes in poor environments. And most importantly, limited access to preventative care. Go back to that neighborhood in Columbus I was just talking about. Why are babies dying in epidemic rates in South Linden, Columbus? The access to neonatal and prenatal care is very lacking among that population. And it's not hard to see why it's lacking. It's not that people don't love their children. I would not argue that. There's not a social there's not a social bridge built between a poor Black segregated neighborhood and a wealthy research institution just 5 miles away. The other thing about the poor nutrition thing is two concepts there I would further talk about. One is the issue of food deserts. You may have heard this concept before. Food desert is defined as an area that does not have within reasonable commuting distance an actual grocery store, like a big box grocery store, access to fresh foods. So people end up buying food the only places that they can, right? Bodegas, corner stores, liquor stores, things like that, or taking the bus very long distances to get to places where they can actually buy groceries, which is also not great for like social efficiency. So the existence of food deserts in poor areas leads to much worse nutrition. Also, the poor are getting ripped off for just about everything. If you take nothing away from this class besides this one point, please let it be this one point. Being poor is really expensive. What do I mean by that? Being poor is really, really expensive for a couple reasons. One, the poor have fewer consumption options. So part of it is a supply and demand issue. If demand is high, but the supply is limited, the cost is always going to go up. And so if you I know I've discussed this before, I want to really make sure I reiterate it here. If you compare the cost of groceries in a low-income area to a wealthy suburban community, who is paying more for groceries? It's not the wealthy suburban community. It is very much the poor, low-income area, because there's likely to be one, if that, grocery store that serves that area, the poor area. That is. So people do not have the option. Now, in the meantime, I look at Ann Arbor, for example, it's got like 3 Whole Foods, a Trader Joe's, 2 Plum Markets, multiple Krogers. All those places have to compete with each other to a degree. So, and I remember this, like back in 2011, I remember that there was like a food crisis throughout the world. And one of the byproducts of that is like milk, which like a gallon of milk used to cost about $2.50. It went up to $4.50, mostly because of supply chain issues. And that's what people had to pay in that time. But if a place wanted to charge $4.50 for milk all the time, if you have options, you can decide to drive somewhere else where you'll get a better price for milk. The poor end up paying essentially whatever the store thinks that they can get away with. And in the lack of options, it turns out sometimes they can get away with an awful lot. Keep that in mind. What I just said is a very important thing to keep in mind for your life, I think, but also long term for this class as well. I think like on Wednesday, I'm going to be talking a little bit about that demand issue for the things that we need. Inequality is also linked to a tremendous amount of psychosocial stress, and that's distributed equally. On the other stuff for poor nutrition, obesity, all that stuff, I was talking mostly there about on the poor side of inequality, but what about the wealthy? I want you to listen very closely to this finding that I'm about to say, because it's very important. Research shows that high-income people in a high inequality area have generally worse health on average than low-income people in a low inequality area. So even the wealthy are suffering as a result of this. It leads us to become workaholics. It leads us to become very stressed about money, because if you're middle class or upper middle class in a high inequality society, you cannot shake the feeling of what it means to be on the other side of this. I'm going to have to do everything I can not to slip to the other side of that, because you know the consequences of being on the other side of the inequality divide. And there's also fear of crime. There's also fear of there's fear of your safety, and that leads to, again, the stress issue. So I hope you guys are really seeing these social determinants of health. They hit everybody and they affect everybody. And that's the reason why the US, despite being one of the wealthiest countries, despite being a country with the highest per capita healthcare spending, does not get better outcomes for it, because our society is not set up to treat the real causes, the real social causes of what is going to end up happening to people throughout their lives. So if we look at this, over the inequality. What I have here is life expectancy by neighborhood poverty group. So we're talking about, like, do you live in a neighborhood around a lot of other poor people or around a lot of other wealthy people? Life expectancy for those living in a neighborhood with less than 5% poverty rates is almost 82. That's essentially what the Germans have. Now, if you go down to one with greater than 30, life expectancy there is about 72. That's the effective poverty. Subtract 10 years off your life. If we look at other gradients of health, we can see that certain groups, even though everybody suffers as a result of this, certain groups suffer more from this. So for example, for Asians and for Hispanics, the effect of neighborhood poverty is certainly much more muted than it is for whites and African Americans, which is a very interesting finding here. It has a lot to do, I think, with how much community support can be marshaled here. There's a lot of research about collective efficacy in Asian and Hispanic areas, which, to be clear, are not immune from suffering from various negative social problems and discriminatory treatment, but they're often able to marshal kind of a collective efficacy response to it in a way that whites and African Americans are not always able to. So if you look at that, like the group that's kind of really dropping off the map here, we can see that the racialized nature here is not equal, despite being poor, kind of for everybody across the board. Now, I want you to consider one of the last pieces of data I'm going to show you on this. From 2010 to 2018, medical advances averted 176,000 deaths. So that's new treatments, that's new medical equipment, that is new drugs, various things like that. However, if you had just equalized the black-white mortality gap, that alone would have averted 886,000 deaths, 4 times what medical advances. So I'm not arguing for a retreat of medical research. I think those people are doing heroic work right now. But I am arguing, and hopefully some of that, like an extra attention on the social determinants of health, is something that comes out of this fucking epidemic that we're all living through right now. We spend billions on the development of new drugs and technology. And if that gets us better drugs and better technology, perhaps that is a good thing. But we don't pay nearly as much attention to what puts people in needing those drugs and technologies in the first place. We spend only a fraction on things like education that might help people avoid these things. Only a fraction of that on labor force support that keeps people out of poverty. That stuff is just ignored in a way that it isn't in a place like Germany, Sweden, or France. Okay, and so what I'm hoping is this is a lesson we take away from this pandemic, because this pandemic is happening whether we want it to or not. But one of the things I'm seeing here is countries are suffering in a somewhat unequal way. Like the US is suffering worse than Germany. Germany has just as many cases as the US does, but they have one of the lowest case fatality rates in the world. For one, Germans trust their government in a way a lot of other countries don't. And for two, Germans follow instructions. We are a rule-following people. Sometimes that's very bad, but sometimes it's very good to follow the rules. So what the Germans have been on top of this social distancing from the beginning. And as a result, even though they're having all these cases, the severe ones are able to be treated because the system is not overloaded by these surges that we're seeing in Detroit, New Orleans, Philadelphia, and New York City at the moment. And like people of color in the United States are very clearly suffering worse. And again, I want to just go back to one of the first things I said today. Do I look at that map and say that the Swedes, the Norwegians are just naturally healthier than the Afghans? No, of course not. So why are people of color disproportionately getting and dying from the coronavirus and the COVID-19 complications? In Chicago, Blacks account for just 1/3 of the city's population, but they are half of coronavirus cases, and they are 3/4 of deaths in Chicago alone. We are seeing similar disproportionate rates in Michigan, mostly driven by the Detroit metro area, New York, mostly driven by New York City, and Louisiana, mostly driven by New Orleans. Why are Blacks more likely to contract coronavirus and to die from the coronavirus complications? Guys, it's not rocket science, and it gives me no pleasure to say it. But this whole lesson today, I hope, helps you understand that in much more detail. It's not like this is not some obscenely new observation to say that because of everything I've just gone through here, that Blacks in the United States more prone to these pre-existing conditions, more prone to these underlying causes of underlying health conditions, more likely to lack health insurance, more likely to lack access to high quality health care, more likely to live in multi-generational homes where they're spreading it like crazy. We are right now suffering as a country due to our inability to equalize these social situations. And if that makes you sad, again, be sad. I mean, I don't want to make you sad, but sometimes it's helpful to just embrace our realities. So anyway, that's what I got for you today. Hopefully some of that stuff gets referenced in the reaction papers. Next time I talk to you on Wednesday, I'll be talking about healthcare. So not just our conditions and determinants of health, but what happens when you actually need healthcare. Thank you very much. Stay safe out there. And I am here to answer any questions you might have.